tonsillitis, patients with mono often describe feeling completely exhausted, and that fatigue may last for several weeks or months. So to help distinguish between mono and viral pharyngitis, providers may order an antibody test, commonly known as the monospot test. This blood test detects antibodies that the immune system produces in response to the Epstein-Barr virus infection. So it's important to remember that the monospot test may be negative during the first week of illness. So if clinical suspicion does remain high, so the patient continues to have symptoms, the provider may repeat the test later or order EBV-specific antibody testing, which is more sensitive, and it can distinguish between a current and past infection. Now let's discuss tonsillitis and adenoiditis, which are two common inflammatory disorders of the upper airway that are especially common in children, but we are focusing more on adults in this course. Although they're closely related, it's important to understand the difference between the two. So the tonsils are two oval-shaped collections of lymphoid tissue located on either side of the back of the throat, and the adenoids are another collection of lymphoid tissue located higher in the nasopharynx behind the nose, where they cannot be seen during a routine oral examination. So both structures are part of the body's immune system, and they serve as one of the first lines of defense against inhaled or ingested pathogens. So they trap bacteria and viruses entering through the nose and mouth, and they help initiate an immune response. So the pathophysiology, tonsillitis occurs when the tonsils become inflamed, while adenoiditis refers to inflammation of the adenoids. Makes sense. Most cases begin after exposure to a viral pathogen, although, again, bacterial infections can also occur. So when microorganisms enter the upper airway, they're captured by these lymphoid tissue. Immune cells recognize the pathogen. They trigger an inflammatory response by releasing cytokines and other inflammatory mediators. And this inflammatory response, it causes vasodilation, increased blood flow, edema, infiltration of white blood cells. So as swelling increases, the tonsils will enlarge and become more inflamed and edematous. If bacteria are responsible, particularly again that group A strep, neutrophils will accumulate and may produce purulent exudates, which appear as white patches on the tonsils. And because the adenoids sit behind the nasal cavity, inflammation can obstruct airflow through the nose. Enlarged adenoids may also block the opening of the eustachian tubes, which increase the risk for otitis media or middle ear infections, which we see in, children more often than adults, but it can happen in adults. So repeated inflammation over time can result in chronic enlargement of the tonsils or adenoids, and this can contribute to sleep disordered breathing or obstructive sleep apnea. So risk factors and causes, most cases are caused by viral infections. Some common viral pathogens include rhinovirus, influenza virus, adenovirus, the Epstein-Barr virus again. And the most important bacterial cause is group A streptococcus, again, because it requires that antibiotic treatment again to prevent complications such as acute rheumatic fever. Other less common causes here would be allergies, environmental irritants such as cigarette smoke or air pollution, dry air that irritates the mucosal tissues. Several factors increase the risk of developing tonsillitis or adenoiditis, again, including young age, particularly our school-age children, any close contact with infected individuals in schools or daycare settings, seasonal viral illnesses, any exposure to tobacco smoke, or a weakened immune function. Clinical manifestations here, patients commonly present with sore throat, painful swallowing, fever, fatigue, swollen tender cervical lymph nodes, and during our physical exam, we'll often observe enlarged tonsils, white exudates or patches if a bacterial infection is present, halitosis, which is bad breath, a muffled or hot potato voice when swelling is really significant, And patients with adenoiditis often have symptoms related to nasal obstruction rather than throat pain. So these include nasal congestion, mouth breathing, snoring, hyponasal speech. So sometimes describe this as a stuffy nose kind of voice, and then difficulty sleeping. So as nurses, it's important to recognize findings that suggest airway compromise. These would include difficulty swallowing secretions, drooling, stridor, increased respiratory distress, difficulty opening the mouth, deviation of the uvula, which may indicate a paratonsillar abscess. So these findings require prompt evaluation because they can signal a developing airway emergency. And then diagnostics. So diagnostics, again, are going to begin with a thorough history and physical exam. The provider is going to ask, or you're going to ask about duration of symptoms, fever, difficulty swallowing, any snoring or mouth breathing, any exposure to sick contacts, previous episodes of tonsillitis or recurrent infections. And then physical exam is going to include inspection of the tonsils, posterior pharynx, cervical lymph nodes, and nasal airway when adenoid involvement is suspected. If we do suspect group A strep, then again, a rapid strep test is going to be performed. Results are going to be available pretty quickly. If the rapid test is negative, but clinical suspicion remains high, we're going to get a throat culture. If, again, patients have prolonged fatigue, generalized lymphadenopathy, or significant tonsillar enlargement, we're thinking again about that Epstein-Barr virus and mono. We might get that antibody testing, the monospot, to evaluate for infectious mononucleosis. And then for patients with chronic adenoid enlargement causing persistent nasal obstruction or recurrent ear infections, our referral sometimes goes to an ENT. Visualization of the adenoids can be performed using a nasopharyngoscopy. This allows direct examination of the tissue behind the nasal cavity, and then potentially surgery will be performed. Next, we have epistaxis. So this occurs when blood vessels within the nasal mucosa rupture, resulting in bleeding from one or both nostrils. So the nasal cavity contains extensive network of blood vessels located very close to the surface of the mucosa, and this rich blood supply helps warm and humidify inspired air, but it also makes these vessels really vulnerable to injury. So approximately 90% of nosebleeds originate from the anterior portion of the nasal septum, specifically an area called Kisselbach's plexus, also known as Little's area. So Kisselbach's plexus is where several small arteries come together, making it really highly vascular and susceptible to bleeding from even minor trauma or irritation. And less commonly, bleeding originates from the posterior nasal cavity, where larger arteries supply the nose. Posterior nosebleeds are generally more severe, and they occur more often in older adults. These are more difficult to control because the bleeding tends to drain into the throat rather than out of the nostrils. Risk factors and causes. So many different causes and risk factors here. So the fragile blood vessels within the nose tend to rupture from dry air, especially during the winter months or in a heated indoor environment, nose picking, trauma to the nose, any frequent nose blowing, allergic rhinitis, viral upper respiratory infections, acute or chronic sinusitis, and then there are several systemic conditions also increase the risk of epistaxis, including hypertension, bleeding disorders such as hemophilia or thrombocytopenia, liver disease, which affects clotting factor production. We'll learn more about that towards the middle of the semester. And then use of anticoagulants such as warfarin, apixaban, heparin, any antiplatelet medications such as aspirin or clopidogrel, known as Plavix. Other contributing factors include cocaine use, which damages the nasal mucosa, nasal tumors, although these are much less common, any recent nasal surgery or nasal packing, But children most commonly experience anterior nosebleeds from trauma or nose picking, while older adults are more likely to experience those posterior bleeds due to hypertension, vascular changes, or anticoagulant therapy. So clinical manifestations, the hallmark finding is bleeding from one or both nostrils. Makes sense, but that with anterior epistaxis, blood is usually visible. It's flowing from the nose, and the patient can often identify which side is bleeding. So and then with posterior epistaxis, patients may instead report blood draining down the back of the throat, frequent swallowing, spitting up blood, a metallic taste in the mouth. So if bleeding is significant or prolonged, patients may also develop signs of blood loss, including dizziness, weakness, lightheadedness, tachycardia, hypotension in severe cases. So it's important to recognize that these symptoms suggest more substantial blood loss and they warrant prompt evaluation. The diagnosis of epistaxis really begins with a focused history and physical exam. The health provider will ask questions such as, when did the bleeding begin? Has this happened before? Was there any trauma? Are you taking any blood thinners? Do you have a history of hypertension or any bleeding disorders? Have you recently had a cold, allergies, or a sinus infection? And during the physical exam, the provider is going to inspect the nasal cavity using a nasal speculum and light source to identify the site of bleeding if they can. If the bleeding is anterior, the source can often be directly visualized. Posterior, again, is more difficult to identify, may require a consult with ENT and specialized equipment. If bleeding is severe, recurrent, or difficult to control, additional lab testing may be ordered. So we may look at a CBC or complete blood count to evaluate for any anemia or thrombocytopenia. Sometimes coagulation studies such as PT, INR, and APTT for coagulation studies in patients with epistaxis to determine whether the patient has an underlying clotting abnormality that's contributing to the bleeding or making it difficult to stop. Sometimes a type and screen is obtained if significant blood loss is suspected. And then imaging studies such as a CT scan, they're not routinely required, but they may be considered if facial trauma, nasal fractures, tumors, or chronic sinus disease are suspected. Our final upper airway disorder is obstructive sleep apnea, commonly abbreviated as OSA. Unlike the previous disorders we've discussed, OSA is not an infectious disease. Instead, it's a chronic disorder characterized by repeated episodes of upper airway obstruction during sleep, resulting in pauses in breathing called apneas. So OSA is one of the most common sleep disorders, and it's often underdiagnosed. And if left untreated, it can significantly affect the cardiovascular, metabolic, and cognitive health of the patient. The patho, to understand obstructive sleep apnea, we have to first consider what normally happens during sleep. So as we fall asleep, all of our skeletal muscles naturally relax, including the muscles that help keep the upper airway open. In most people, the airway remains open enough to allow normal airflow. In patients with OSA, however, the upper airway becomes partially or completely obstructed during sleep. And this obstruction is usually caused by a collapse of the soft tissues of the pharynx. And even though the patient continues making an effort to breathe, air cannot move effectively through the narrowed airway. So an apnea episode is generally defined as complete cessation of airflow for at least 10 seconds, while a hypopnea is a partial reduction in airflow accompanied by decreased oxygen saturation or arousal from sleep. So as oxygen levels begin to fall and carbon dioxide levels rise, the brain is going to recognize that the body is not receiving adequate ventilation. So this is going to trigger a brief arousal from sleep, causing the patient to partially awaken just long enough to restore that muscle tone and reopen the airway. Breathing is going to resume. It's often accompanied by a loud gasp, snore, or choking sound, and the patient usually has no memory of these awakenings, but they may occur dozens or even hundreds of times each night, preventing the patient from getting restorative sleep. And over time, these repeated episodes of intermittent hypoxia and fragmented sleep activate the sympathetic nervous system, which increases inflammation and places significant stress on the cardiovascular system. So So that's why we don't want this to happen, or otherwise be able to get them on some sort of treatment. Risk factors and causes. So several anatomical and lifestyle factors increase the likelihood that upper airway will collapse during sleep. And one of the strongest risk factors here is going to be obesity. So any excess adipose tissue around the neck and pharynx narrows that airway, making collapse more likely when muscle tone decreases during sleep. Other important risk factors include large tonsils and large adenoids, a large tongue, craniofacial abnormalities such as a recessed jaw or narrow airway, increasing age, male sex, although women are also affected, particularly after menopause, family history of obstructive sleep apnea, smoking, alcohol consumption, especially before bedtime, any sedation medications or sedative medications, however, these are going to further relax airway muscles. Sometimes certain endocrine disorders such as hypothyroidism can also contribute to airway narrowing. Clinical manifestations. So many patients are unaware that they have sleep apnea because the symptoms occur while they're asleep. Often a spouse or family member is the first person who notices the problem, but common nighttime symptoms include loud, chronic snoring, witness pauses in breathing, again from the partner, gasping or choking during sleep, restless sleep, frequent night awakenings, and because sleep quality is poor, patients are commonly experiencing daytime symptoms such as excessive daytime sleepiness, fatigue despite sleeping for many hours, morning headaches, difficulty concentrating, memory problems, irritability or mood changes, decreased work performance, and patients may also report waking with a dry mouth or sore throat due to repeated mouth breathing overnight. So, as nurses, it's important to recognize that these symptoms are often subtle and develop gradually over many years. And then finally, diagnostics are going to begin with a comprehensive history and physical, of course. Providers are often going to ask about loud snoring, any witness apneas, daytime sleepiness, morning headaches, difficulty concentrating, sleep habits, any alcohol or sedation use, family history. And then the physical exam is going to include evaluation of body mass index, neck circumference, airway anatomy, tonsil size, nasal obstruction. And then there are several screening questionnaires that may also be used. One of the most common is the Stop Bang questionnaire, which is going to evaluate factors such as snoring, daytime tiredness, observed apneas, high blood pressure, BMI, age, neck circumference, gender. And patients with higher scores are considered at increased risk for obstructive sleep apnea. The gold standard for diagnosis is an overnight sleep study. And during this, several physiological parameters are monitored simultaneously, including airflow, oxygen saturation, respiratory effort, heart rate and cardiac rhythm, any brain activity using an EEG, eye movements, and muscle activity. So these measurements are going to allow providers to determine both the presence and the severity of obstructive sleep apnea. And some patients may also qualify for home sleep apnea testing, particularly if they have high likelihood of moderate to severe obstructive sleep apnea and no significant cardiopulmonary or neurologic disorders. The severity of OSA is really determined using the apnea-hypopnea index, which measures the average number of apnea and hypopnea events per hour of sleep. Mild is generally 5 to 14 events per hour, moderate is 15 to 29, and then severe is 30 or more per hour. All right, that was it for today. I can't wait to see you in class and talk more about the treatment, complications, nursing considerations, and nursing interventions. I will see you then.